Good afternoon, and thanks for joining us for Healthline 3, our conversation today. And I'm Courtney Butts. Healthline 3 is a 30-minute conversation dedicated to practical ways to help you live a healthier, happier, and pain-free life. And we also invite you to join in the conversation. We'll be taking your calls and answering any questions that you have live. But when you do dial in, make sure you're in a quiet space and that your TV's turned all the way down so that we can hear your question clearly. The phone lines aren't open just yet. You'll see that at the bottom of your screen, that phone number 318-219-4569 when those phone lines are open. And joining us for today's conversation is Dr. Syed Mehmood, cardiovascular surgeon with Red River Cardiovascular Surgery. Thanks for being here.
Thank you for having me.
Absolutely. So today our conversation, or our topic, is going to be focused on cutting-edge, minimally invasive repair for the heart. So you are a cardiovascular surgeon, but you're also the director of the structural heart program with Willis-Knighton. So tell us first, before we get into the topic, what you do and what your different roles entail.
I think I got 1 foot in the old-fashioned way and 1 foot in the way of the future, the way things are going right now. So I spend almost half the week doing it one way and the other half the week doing the other way. So I get best of both worlds.
Okay. So, and you mentioned in our midday newscast that, like you said, the old-fashioned way, maybe more like open heart surgery. Is that what you're talking about?
Yes, open heart surgery. Everything is going more and more minimally invasive, but we looked at the data. We see what is the best for each patient and what age group, what comorbidities, meaning if you have diabetes or blood sugar, and you will actually be better with open heart, the old-fashioned way. If you don't have that and have less calcium, maybe there's not much difference between open heart surgery and stenting. So we have very good data, and we try to be as objective as we can.
Right.
And we always take care of what the patient preference is too. So it's my job to educate, but in the end it's the patient job. I mean, this is to choose whichever treatment or no treatment they want.
Right. And do you ever work in some situations, in emergent situations, where the best case scenario would unfortunately be open heart surgery at that point?
All the time.
Yeah.
Just 2 weeks ago I did one. But most of the time, even at that time, I try to get the patient's wishes and the family wishes. Let's say the patient is incapacitated for some reason and the family wishes come. And it's not the family wishes per se, it's whatever the patient has told them. If they have a directive saying, no matter what, I don't want open heart surgery, it's their choice. And that happens sometimes.
Right. Okay. So so with the minimally invasive heart repair, that's more of, like you said, the modern, more advanced or more advancements that you're seeing in your practice. So talk a little bit about what you've seen over the past several years that you've been practicing, with the open heart surgery techniques, but now with these minimally invasive techniques, and how you're seeing patient outcomes improve.
For sure. I'll tell you, 2 years ago we started doing this procedure. It's called Barostim. It's for heart failure, and it's a very easy procedure. It's outpatient, takes me around 30 to 45 minutes to do it, and patients come in the morning and they go home the same day. But people who have really poor heart function, means the heart is very weak. They get short of breath. They need to sleep on 2 pillows. They can't do any chores. But with this device, 90% of people feel better, and they're hospitalized less because they're not going through that vicious heart failure cycle. So that's been, I think, a godsend for a lot of our heart failure patients in Shreveport. I think we've done the second highest in the nation, which is 53 in 2 years, which is a decent number. Other things that have come along is, when I started practicing, it's 2009, TAVR wasn't approved yet. It got approved, and then I saw the writing on the wall. I went back to school, learned how to do it, and we've been doing it for 10 years now. Probably over 1,000 we've done in Willis-Knighton with very good results. And then I think 4 years ago is when we got the MitraClip, which is another valve. So TAVR is a valve that goes into the aortic part, so the top of the heart. Then the mitral is the Achilles heel. It's a very difficult valve to treat. The MitraClip actually fixes maybe 50% of the problems. TAVR can pretty much, it's 99.9% of the people can have TAVR. MitraClips, maybe half of them can have MitraClips, but we have a lot of new technology coming to address that with better results I think that will be more, that we will be able to help more people minimally invasively. The other things we have done as a practice is, we can use a robot to do, instead of doing a complete sternotomy, we can make a little incision over here and put these ports with the robot and try to use that to do that. It's called robotic cabbage, coronary artery bypass grafting. We do have a minimally invasive mitral valve program that some of my partners are more involved in than I am, and we're trying to develop that side of the practice too. So even the open heart is getting more and more minimally invasive too. So.
That's amazing. And so you've talked about heart failure and the structural part of, fixing those structural issues within the heart. What are some of these diagnoses that patients come to you with? So those at home, maybe they are struggling with this specific diagnosis, so they can have, more of that connection with what you treat.
Sure. One of the treatments we do is for, the most prolific treatment is for coronary artery bypass grafting. That's for when you have lesions in your heart vessel at certain locations that cannot be treated medically and cannot be treated with stents. That's when we come in. It's called a coronary artery disease, and it has to be pretty proximal, which means it has to be closer to the heart, to the start of the flow, where we come in. Other things we can treat is for TAVR is for aortic stenosis mostly. It can be usually we prefer it in the older people. TAVR has been around for 10 years. We have very good data that's 10 years old, but we don't have 15, 20-year-old data. For open heart surgery in people who are especially younger than 65, or especially if they're younger than 55, we prefer that side. If they're 55, we'll put in a valve that's made out of metal, but it'll last forever. We can use a tissue valve if you're older, in between the sweet zone. And then TAVR is pretty much taking over most of the tissue valve business right now, TAVR is a kind of tissue valve, and it's for aortic stenosis. Where the aorta gets too tight, there's a valve there, it gets smaller and smaller, and we can go and expand it. Sometimes in special cases, if the valve is leaking, we can also deploy it, but it's kind of scary. Open heart surgery is better for it still.
Interesting. And you mentioned heart failure as well. And which one was that one that we talked about at the beginning? What was that called?
It's called Barostim.
Barostim. Okay.
It does something to your reflexes. So in the human body, there are two different kinds of sympathetic system. The parasympathetic system, which lowers your blood pressure, and sympathetic, which increases your blood pressure. And it modulates that and your brain to lower your heart rate and decrease your blood pressure, makes it a little easier for your heart to pump. So like on a bad engine, you're putting a little bit of a turbo and getting you a little extra. And it works most of the time.
Oh, very interesting. And I think about this time of year during the holidays. We just had Thanksgiving, where a lot of people are enjoying, things that are high in sodium and maybe extra fluid, which are two things that you want to watch out for with heart failure. Do you see a lot of heart failure exacerbations this time of year?
100%.
Yeah.
We see a lot of, when I used to live in the north, this is when people used to start shoveling snow, and a lot of heart attacks would come.
Oh, wow.
Right after a snowstorm, especially the first one. That's when you get because they haven't really worked out. That's the first workout to do, and that's when they had heart attacks. And heart failure too. Thanksgiving, right after Thanksgiving, we have a whole slew of heart failure patients. They go to this family gatherings. They don't pay as much attention to the sodium intake. And Christmas, unfortunately.
Oh, right. Yeah, we're about to enter into another probably round of exacerbations, and I know we're kind of jokingly saying it, but it is very serious, and you want to maybe take good care of yourself for sure. Now, with the Barostim, does this decrease the risk of exacerbations?
Yes, it decreases. It's known to decrease your hospitalization. Let's say New York Heart Classification 3, which is just pretty bad. It's not as bad as 4, in which you use drugs or you need a heart transplant or VADs, but it's almost there. It decreases your admission from 5 or 6 times a year to 1 or 2. So it reduces a lot.
That's incredible. Okay, so tell us a little bit about Willis-Knighton, and it's a 2-star designation, and what does that mean?
Well, let me tell you, it's 2-star out of 3.
Oh, wow.
And then we are better than almost 85% of the program. So star designation is, there you can be no star, 1 star, and 2-star. It just tells you about our outcomes, how good outcomes we have, what quality care we give, and the difference between 2-star and 3-star is like 1 or 2 patients that missed 1 or 2 doses. It's very stringent. You have to be perfect to be a 3-star. We're almost there.
Yeah, that's incredible. And like I said, we have this technology, we have this incredible care right here at our fingertips for the patients here in Shreveport and the surrounding areas. I'm sure that you treat not only patients in the metropolitan area of Shreveport, but also, several hundred miles away from now.
Yeah,
from
Texas, we get a lot of patients from right south of us, north of us, Texarkana. A lot of patients prefer to come to us, Arkansas, Ark-La-Tex area. We're a big hub. I think if you look at Willis-Knighton, we are probably the biggest provider in the northern area when it comes to hospital staff and the quality of care as well as the facilities we have.
Absolutely. Well, if you're just joining us, you see that we have those phone lines open. That number to call is 318-219-4569. We're talking with Dr. Syed Mehmood about minimally invasive cardiac repair techniques. If you have, we've mentioned aortic stenosis, coronary artery disease, heart failure, any of those maybe structural heart components that you are interested in learning more about, then we would love to hear from you. So, tell us about, you talked about the mitral valve clip, right?
Yes,
and then TAVR, so you mentioned a lot of patients are eligible for TAVR, but mitral valve only about 50%. So why, or who is eligible for the mitral valve, and why is it kind of a little bit more selective?
The clip is the first generation technology. The TAVR we have right now is fourth generation. The first generation, not everybody could do it. The clips, you have to have a regurgitation, which means that it's leaking really bad, and it has to have a specific area, because when we put the clip, literally we are tying it in the middle. You're reducing the area, so if you're not careful, you can cause stenosis. So the valve area, the size of the hole has to be good enough. Both leaflets have to be good enough. But now we have a technology which we can go in and just deploy a valve in there, which is, the data just came out, is great. It's not FDA approved yet. It's only in the big centers under trial, but I foresee in the next 6 months to a year and a half, it'll be out.
Amazing.
And we're going to try our best to get it over here.
Okay, we have our first caller, Charlotte. Thanks for joining us, and what is your question?
Dr. Mehmood did a triple bypass on me June the 6th, and said that I would need a stent later on, and I'm wondering how long that would be before I have to go in and have another stent put in.
That would be a question to ask your cardiologist. I try to, whenever I do a bypass, I do all the major vessels. Only if you're having symptoms would you require a stent. You probably don't need it. Otherwise, I would have made sure you got it before you left.
Okay, thank you.
Oh, for sure. And
that answers my question.
And just call my office. I'll see you and talk to you in person.
What is that phone number, or how can we get in touch with you? What's the best way?
It's 318-227-9777.
Okay, pretty easy. 227-9777.
That's right there.
Oh, there we go. Great.
All right. Thank you so much.
Anytime.
Yeah, thanks, Charlotte. And if you're just joining us and you have a question for Dr. Mehmood, give us a call. That number is 318-219-4569. And you mentioned a good point. Just because you have surgery with cardiothoracic surgeon, you still want to follow up with your cardiologist.
100%. It's why I love my field. I fix people, and then the cardiologists maintain them. So.
Okay, yes, and I always ask this question too, that these medications that people are on nowadays, or even just the surgical interventions, make people feel so much better, and a lot of times that can make people think, oh well, I'm fixed 100%, so that means that I can now stop taking my medications. And what would you say to that patient?
I always give the same lecture: is I'm no God. I use stuff that's meant for something else to try to fix it for you. But if you don't take care of what I put in, like the artery that goes down to your heart, the main vessel, and the veins, if you smoke and you don't pay attention, your cholesterol goes up, and you do whatever you like, you don't adopt a healthy lifestyle, whatever I do is going to shut down. So you need to maintain a healthy lifestyle, maintain your cholesterol, stop smoking, if you want that stuff to last.
Right, absolutely. So what are some of those symptoms that people should be looking out for that would make them maybe a candidate for any of the interventions that you've mentioned?
For sure. So for let's start with aortic stenosis. Aortic
Sure.
stenosis will usually give you either chest pain, it can give you dizziness, can give you shortness of breath, especially on exertion. When you go to a physician and you go to him regularly, there's usually a murmur, which is the you can hear the heartbeat and it's off a little bit. That's what a murmur is. And usually your cardiologist is keeping an eye on it. So that's for aortic stenosis. Aortic regurg is just your heart starts failing, so you can have leg swelling and you can have shortness of breath with that too. Mitral regurgitation is you can have the similar issues with that. Your heart starts failing, you can have leg swelling and shortness of breath. Very common in mitral regurgitation is you require maybe 1 pillow, then 2 to 3 pillow, otherwise you get very short of breath. It's called
At night?
At night. Yeah.
Okay. Interesting. So when you lay down at night,
Yes.
short of breath, can't maybe fall asleep, have a hard time sleeping
Oh
as
yeah,
well?
you have to almost sleep sitting up.
Wow. Okay. Because of gravity, or how does that work? With
your heart has too much fluid on board, and when you lie flat, it actually returns more. If you're up there, some of it's pulling into your legs, and makes you feel better.
Interesting.
For mitral stenosis, it's you start having very bad leg swelling, kidney issues. So it's just blocking different parts in the pathway. So.
Okay. So you mentioned in our midday newscast, and I can't remember the name of it, but something that's coming down the pipeline in the next, you said 6 months or so? What is
6 months
that?
to a year and a half. There are new devices, and MitraClips does, like I said, only works for 50% or less, or around there. This is a valve we can put in, and that's supposed to be more broadly accepted, and at least what the data is showing. So we are hopeful a lot of people for which the orifice was too small, or MitraClip results are okay, they're not the best. If we can have this valve, at least in the studies, it has great results and really good mortality. And it's a difficult problem to fix, but I think this device, at least if you look at the data, is showing that they have fixed it. You never know till it comes out. These studies are usually a couple hundred people, but till you put thousands and thousands in them, you just don't know.
Right. Okay. And so this would be treating the mitral regurgitation?
Yes, ma'am.
Or leaky valve?
Leaky valve
okay.
and some stenosis too.
Nice. So, and like you mentioned, is this kind of like another generation of the interventions? So it's going to help even hopefully more people, like the TAVR?
Yes, more
Yes.
people with the TAVR without opening their chest up.
Very cool.
It's still 6 months to a year and a half away.
Right.
And that's before we get it. And first we'll do it in the easiest patients. And as we get more experience, the nation gets more experience, you can open it up to other people.
Mm-hmm. So I'm sure this is an exciting time for you as a doctor and provider to just with all these new advancements.
Oh, for sure. Keeps life interesting.
Absolutely. So you keep saying minimally invasive. So we obviously know open heart surgery, that is an invasive surgery,
Yes.
and that is a very difficult recovery. Tell us, what are you doing to make this minimally invasive? Like where are you accessing the heart, and what does that process look like?
So something that new the people have been trying it for a long time, but the robots are also on the 3rd and 4th generation. They're finally good enough that we are having better success in doing a lot of these things. So if you require a single vessel bypass, that's the main artery. There's an artery that goes on the left side of your chest. We take it down and put it on your heart, and then we make a little cut on the left side and then put it through there, so without opening a sternum. So robotic CABG is usually one vessel. That's I think is becoming more and more common, and 2 of my partners are pioneering it over here. So if you need that, and that is the true benefit for open heart surgery, is the lima, the main vessel on top, and the artery that gives us CABGs its superior results. So we're trying to emulate that. If you go to, let's say, for example, Denmark, that's all they do. They do lima LED, the one we're doing with robot, and just stent everything else. Stenting with other vessels, there's not much difference. Unfortunately, a lot of times in our population, the disease is so progressive, it's hard to stent. It's too much calcium. Stenting is risky, so those patients we still have to do it open heart, because you can't do it from below. You can't see below because the heart is on top. When we do surgery, we stop the heart and we can look easily. With the beating robot, you just can't see below without opening the chest up.
Mm-hmm. Would you say that with the minimally invasive techniques, you have to be more precise of a surgeon versus when you do open heart surgery? Or, I mean, I'm sure both apply in both situations.
I think both apply with both situations. I think technology and AI is getting to the point that maybe in 10 years, you just tell the robot, this is where I want you to do it, just do it, and you should be able to do it.
Wow. Yeah. Yeah. And a lot of people get nervous when you say robot. Can you put some people at ease in how this is making you more precise and more of an accurate surgeon?
It is. It's just instead of me putting my hands in your chest, we're using long instruments that are still controlled by my same hand, so they're just as precise.
Right. Okay. Good deal. Okay. So have we talked about an angiovac? If not, what is that and what does it treat?
Sometimes you can get an infection in your heart, especially the right side. It can be because you have an infected device, or unfortunately, some people use drugs. Just 2 years ago, we would have had to open people's chest up and replace that valve, the tricuspid valve. That's the one that gets infected the most. But now we have this device in which we can just go in through your groin and just suck the infection out. And 90% of the time, that's all you need to do. So we don't have to open your chest just because of that.
Okay, nice.
I think we've done like 7 of those last 2 years in Willis-Knighton.
So it's not very common, but there is a method to help when those situations do arise.
Yes.
Okay. So for those that aren't familiar with the heart's anatomy, we're talking about all these different valves. Can you break down those different valves and which ones you're treating for at times?
So in humans, we have 2 circulations. One circulation takes blood to your lungs, brings it back, and then takes the blood from your lungs to the rest of your body. It's called right side, left side. For the right side circulation, the veins, the big things you can see on my arm, right here, popping up in your legs, they bring the blood back centrally. It goes through your right side of your heart and goes through your tricuspid valve. So that's why if you have an infected device or you shoot drugs, that's the first valve the bugs see, and that's most likely to get infected. Then you have a pulmonic valve. It's very rare that gets infected. That's a thing that prevents the blood from the lungs from going the wrong way. So the pulmonic valve keeps the blood from going only one way. These are all just one-way valves.
Gotcha.
Then it goes to your lungs, where your lungs will breathe oxygen and get rid of the carbon dioxide. And then it goes to the left side of your heart, and then the blood sees the mitral valve. That's the one we were talking about, the mitral clip. The mitral valve, again, is only a one-way valve. It's preventing the blood from returning from your heart back to your lungs. Then the heart beats, and then it pushes this to your aorta, and the aortic valve, which feeds your body. That's the artery you can feel pulsating in your arms and your neck and stuff. So.
Very interesting. It's so fascinating to hear, because the heart is such a machine, and there's so many things that it does within a millisecond. So, but you said one way. They should all be working in one way. But when there's issues and there's the leaking, that's when there's
they're going back and forth.
Okay.
And then the body's compensation for the back and forth, it gets dilated, and that's when you go into heart failure. And that's why people say you got a big heart. That's not it's good in some ways, but in medical
good metaphorically, not literally, right?
Not literally, no.
Okay. Yes. So an enlarged heart, that basically means it's because it's working harder to do its job.
The body is trying to compensate, and the way it compensates sometimes, let's say for example a valve is leaking bad, like the aortic is leaking, so you have more blood in the ventricle than it should be, so it's dilating up to kind of accommodate it. But if it dilates up too much, then it starts making the mitral valve leak because it's not approximating. So a little bit of dilatation is good and normal, but too much of it causes more failure. So it's a vicious cycle you can get into.
Absolutely. Okay, so if someone maybe doesn't have these conditions, how can someone prevent their risk? I know that these are a lot of times chronic conditions, and they happen over a very long period of time, but what are some of those things that we can start today to prioritize to prevent those?
Well, there's one thing you can't change is genetics. If you have a strong family history of aortic stenosis, coronary artery disease, or even dissections, go talk to your primary, make sure you see a cardiologist, make sure they're looking at everything. Don't smoke. exercise, keep your cholesterol under control, eat healthy, and then enjoy life.
Yeah. Right. Maybe less stress, right?
Well, stress is stress.
Oh, right. And would you say that those other factors actually play more of a role than stress? Like, so if you don't have
So, I always say my happiness is a state of mind. Maybe something I say. You can let things stress you, or you can let things not stress you. If something stresses me out too much, I just don't do it. But I am in a unique position too. I think, stress is bad, and it can overcharge all these things. Like caffeine is not that good for you. Same thing with smoking. Smoking actually causes harm, it's known, but caffeine can cause arrhythmias. Lack of sleep can cause arrhythmias, can cause depression, and all those things. So it's a well-balanced life, and whatever you need to do to de-stress yourself. And if something is stressing you out too much, try your best not to be in situation. I know sometimes it's unavoidable,
right,
but
right. And for those situations where they had to, like a patient had to have surgery, or they know that they have aortic stenosis or heart failure, in some cases, you can maybe get some of that heart function back, but in some cases it's maybe progressed so much that surgery is the inevitable. But what are ways that patients that know that they've been diagnosed with these things to preserve their function as long as possible?
I think the best thing to do is go to your cardiologist. Sometimes if it gets dilated, we can help, but sometimes it's too far gone. If you wait on it too much, it's just like you have brakes and you have rotors. If you don't pay attention to your brakes, it's a simple brake job. Then the rotors, and there comes to a time that whatever, the axle is gone. So if you wait too long, then the axle is gone. There's nothing I can do. But if you come to us early, we can just do a simple brake job and you'll be set. Or some brake job with rotors sometimes,
right,
cabbage with valve, and you'll be okay. But if you wait too long, it's just too late.
Absolutely, yeah. So start early, especially if you start to see those symptoms. So a final question before we wrap up. What direction do you see cardio or cardiac surgery going in the future? All these techniques that you've implemented in your practice already. You've mentioned a couple things that are down the pipeline, but what do you personally see for the future of what you do?
I think it's in the next 10 years, 15 years, we'll be doing things less and less the old-fashioned way, which means opening up your sternum. It'll be more these new technologies coming in as they get more invasive, as the younger generation who are trained younger are more comfortable with it rather than the old generation. Sometimes it's hard to tell older cardiologists, older surgeons that it's time for change, but eventually the young generation comes and that's how they learn. So I think it's coming. And it'll have a more and more penetrance, means patients as they get educated now, everybody has Google, Gork, I don't know, ChatGPT, whatever. You can ask any question in medicine and they're pretty decent on there. There's not medical advice.
Right.
It's the doctor only, but if you want some layman, any of these AI agents are better than any, I think, a layman. So.
Yeah, and it's crazy how AI is. Do you guys use AI in your practice, like integrated at all yet, or do you see that happening in the future?
It is. Sometimes on the medical record sides, we are using AI to do a lot of things. Not really in medicine yet. For medicine, it's a long approval process, but personally, I almost never do a Google search anymore. I just do AI search. It's so much simpler.
Right, yeah. It just kind of gives you spits out exactly what you're looking for instead of having
20 pages,
to.
Yeah, and doing it in my brain.
Yeah, I mean, you've got to save your brain power for what you're doing in the surgery room. So.
No, my 3 daughters, they take most of my
and that too.
But the surgery stuff, I've done 10,000 of these. It's easy peasy.
Okay, yeah. And that's what you want to hear when you go to a surgeon, right? You want to hear those things. So, okay, so if somebody is interested in getting set up with care with you, how do they find you?
Just call our office, 313-585-5845. So I'm giving you my cell number, but you can call my cell number too. You can call my office, 318-227-9777, or you can go to Willie K website and our information is all there.
All right, and you can there was that on your screen as well. You could also look up his name on Google.
Yeah.
That's also pretty easy to find as well, or
Or
AI.
ask or ChatGPT and all those things.
All right, sounds good. Thanks for joining us. This will be on our website, ktbs.com/podcast.